So the question I was going to ask is define the impact on patients' lives, which I think you've already done to a great extent. But how bad does it get? How withdrawn do these patients get? How immobile do these patients get in your experience as the kind of people who are probably treating some of the most complicated patients?
So most of the time, people live with their disease. And most of the time, they live with their disease for a very long time. It is usually a gradually progressive disease. There is a subset that tends to be more rapidly progressive. That's the exception rather than the rule, but we certainly do see that. In point of fact, one of the things that has certainly been an issue of concern for many of us for many years is that we have tended to lump all COPD the same and treat it all the same. And all COPD is not the same. And just as we have moved in recent years away from treating all cancers the same, we need to start moving away from treating all COPD the same. There's certainly some recent data that's come out from a very large study that both Frank and I have been involved in called COPD Gene, which suggests that COPD progresses in different ways. That there's a group that does progress that tends to have more of an emphysematous phenotype, if you will, through the classic, gets more and more severe obstruction. But there's another group that tends to go to a more restricted pattern and then more rapidly down to a progression that perhaps we need to view in a different fashion. This is all that's changing in front of us, but I think we all recognize the need to move away from treating and dealing with it all the same.
So let me ask a question, and let me bring what you just said over here, right? Are there ways for you as a clinician or for you as someone who's looking at it in an aggregate from the claims point of view to try to identify who those rapid progressors are versus the slower progressors are, and do you stratify their care differently?
So this is actually an important question, but it's not a question that we would target differently right now. Right now, our therapies are not convincingly effective in preventing progression. They're to optimize a given person's lung function at a given time and to improve their quality of life. We can affect exacerbations, and I'm sure we'll get into that in a little bit. But as far as the gradual decline, which we know happens in these individuals over time, we've not convincingly proven that we have the therapies that can affect that.
Although there is some suggestion that if we did it earlier, maybe we could make a difference.
Certainly with smoking cessation, that's the case. Yeah. With the drugs we have, early suggestions, but I think we need better therapies to convince with that.
Maria?
Yeah, I think we tend to follow guidelines, and so as well as U.S. preventative task force measures. So certainly smoking cessation, huge opportunity. 50% of our chronic conditions are driven by bad behaviors. Smoking cessation is one of them, and particularly in this disease can make a big impact. And an impact also on cancer prevention as well. But going back also to the diagnosis, right? Even just making the diagnosis with spirometry, we see so much variation that patients may be labeled and not have the disease, or have restrictive lung disease and not have COPD. So the ability to get the right diagnosis in play to hopefully have the right treatment approach that follows. Other opportunities certainly in terms of pulmonary rehab. As a health plan covering pulmonary rehab, and how few patients avail themselves of a benefit that exists. And then I also think the clinical inertia, the adherence, even better training with devices and related to technique and inhalation, because obviously that matters. The best drug, unless it's taken appropriately, is not going to have the desired impact. Also prevention in terms of flu vaccination, pneumococcal vaccines. These are the things that at a macro level we tend to be very focused on. They impact our rating scores, our quality metrics, and have a major impact on cost of care as well.
So I think we all agree with everything you just said. I think that, and I know we're going to talk a lot more about the medications, but I do want to stress, and I'm sure Frank feels this as well, that pulmonary rehabilitation and exercise programs in general are tremendously underutilized in this population. There's some data suggesting that somewhere between 2 and 5% of the 30 million people in this country with COPD ever complete pulmonary rehabilitation. In New York City, where I practice, there may be half a dozen at most pulmonary rehab programs for a population of millions of people. For a therapy which clearly is very effective, that's really just not acceptable. And it's gotten progressively worse, actually, since the national reimbursement policy went into place, because the reimbursement rates are just not sustainable. I assume it's similar in Pittsburgh, Frank?
Yeah, so pulmonary rehab, one of the problems with it, it's almost never accessible in rural populations, and there's incredible variations even in cities. So the Cochrane review on pulmonary rehab said, we're not doing this anymore because it's convincingly effective in improving quality of life and exercise tolerance. So just do it. Unfortunately, it's not being done. 3 to 5%, as Byron said.
Let me just, before we leave, because I don't want to forget, Frank mentioned rural disease, rural America. There's a tremendous amount of data that's come in recent years that people who live in rural America are at far greater risk of having COPD and progressive COPD, even those who live in an urban environment. It's an area, again, which is really difficult because that's an area in particular where the number of practicing pulmonologists is frighteningly small, and the number of rehab programs are even smaller.